Let me start with something that I think will genuinely surprise you. You can have a completely normal cholesterol panel. Your LDL number can be in the acceptable range. Your HDL can look fine. Your doctor can review your results and tell you everything looks good. And you can still be carrying a significant and dangerous load of arterial plaque, the kind that sits quietly, builds gradually, and in the worst cases, ruptures without warning and causes a heart attack in someone who was told just months earlier that their heart was fine. I say this not to alarm you, but to correct a misunderstanding that I believe is genuinely costing people their lives. The misunderstanding is that cholesterol numbers tell you everything meaningful about your arterial health. They do not. They tell you one part of the story, and the parts of the story they leave out are often the most important ones. What I want to talk about today is what is actually happening inside your arterial walls, the real biology of plaque formation and plaque progression, and specifically what you can do each morning with ingredients you may already have in your kitchen to support the biological systems that work against plaque at its most fundamental level. This is not about replacing medication. If you are on statins, antihypertensives, or antiplatelet therapy, this conversation is about what you can do alongside that care, not instead of it. Everything I share today is nutritional support for your vascular system. Your doctor remains your partner in managing any diagnosed cardiovascular condition, and any meaningful dietary change is worth mentioning at your next appointment, particularly if you are on medications that affect your blood pressure, clotting, or lipid levels. With that said, let us talk about what is actually happening in your arteries. Your arteries are not simply passive pipes that blood flows through. They are living, dynamic structures whose inner surfaces are constantly responding to the biochemical environment around them. The innermost layer of your arterial wall, the endothelium, is a single cell thick. One cell. Remarkably thin, remarkably important. Under healthy conditions, the endothelium produces a molecule called nitric oxide, which keeps the arterial wall relaxed, flexible, and essentially slippery, resistant to the adhesion of particles and cells that would otherwise begin to accumulate. When the endothelium is healthy and nitric oxide production is adequate, blood flows smoothly and arterial walls remain clear. But when the endothelium becomes damaged or inflamed, through oxidized LDL particles, through chronically elevated blood sugar, through persistent low-grade inflammation, through the oxidative stress that accumulates with age and poor diet, it loses that protective function. Nitric oxide production falls. The arterial wall becomes sticky, and that stickiness is the invitation for plaque to begin. Here's the part that most people have not been told, and the part that changes how you think about this entirely. Arterial plaque is not a passive deposit, like grease accumulating in a pipe. It is a living, metabolically active structure. Inside every plaque, there are immune cells called macrophages that have engulfed oxidized LDL particles and swollen into what cardiologists call foam cells. There are smooth muscle cells that have migrated into the plaque. There are cholesterol crystals and calcium deposits, and a fibrous cap that forms over the whole structure. A stable plaque, even a substantial one, may sit quietly in the arterial wall for decades without causing a problem. The fibrous cap holds it contained. The inflammatory activity within it is low. The structure is intact. A vulnerable plaque is a different matter entirely. When the fibrous cap is thin, when the inflammatory signals inside the plaque are dominant, when the macrophages within it are secreting enzymes that erode the cap from the inside, that plaque can rupture with almost no warning. When it ruptures, the lipid-rich core is exposed to flowing blood, a clot forms rapidly around it, and the result is the kind of sudden, catastrophic arterial blockage that causes a heart attack or stroke in people who had no idea they were at risk. This is why the real target of vascular health is not simply your LDL number. The real targets are reducing oxidative stress on the endothelium, restoring nitric oxide production, suppressing the inflammatory signals that make plaques unstable and vulnerable to rupture, and supporting the enzymatic processes that allow your body to gradually stabilize and reduce existing deposits. That is a specific biochemical job. And certain compounds, consumed at the right time, in the right combinations, are genuinely well suited to it. Let me walk you through the 4 biological mechanisms that make this possible. The first is nitric oxide restoration. Nitric oxide is arguably the most important molecule your arteries produce. It signals the surrounding smooth muscle to relax, which widens the vessel and reduces blood pressure. It coats the endothelial surface in a way that physically prevents platelets and oxidized particles from adhering. When nitric oxide production drops, which happens progressively with age, inflammation, and inadequate nutrition, arterial walls stiffen, platelet adhesion increases, and the conditions for plaque formation become far more favorable. The enzyme responsible for producing nitric oxide is called endothelial nitric oxide synthase, ENOS. Think of ENOS as a valve operator in a large water distribution system. When it is working, water flows freely throughout the network. When it is shut down by oxidative damage, pressure builds and debris accumulates at every junction and bend in the pipes. Certain dietary compounds, specifically nitrate-rich foods and specific polyphenols, directly support ENOS activity, restoring nitric oxide production even in endothelium that has been compromised by years of oxidative stress. The second mechanism is reverse cholesterol transport. This is the process by which your body pulls cholesterol out of arterial walls and returns it to the liver for elimination. It depends on HDL cholesterol, but not simply the quantity of HDL. What matters far more is the functional capacity of your HDL. Specifically, its ability to pick up cholesterol from the foam cells embedded in plaque and escort it back through the bloodstream to the liver. Standard lipid panels measure the amount of HDL in your blood. They do not measure how well it is working. And this distinction is clinically significant. Certain plant compounds, particularly organosulfur compounds found in specific foods, enhance HDL functionality rather than simply raising its count. When reverse cholesterol transport is working efficiently, existing deposits can genuinely begin to shrink. This is the biology behind plaque regression, and it is real, measurable, and reproducible in controlled research. The third mechanism is macrophage modulation. Inside every arterial plaque, the macrophages that have become overwhelmed by oxidized cholesterol, the foam cells, are not simply passive residents. They are actively secreting pro-inflammatory molecules that erode the fibrous cap from within, making the plaque increasingly vulnerable to rupture. When pro-inflammatory signals dominate, these immune cells behave like arsonists rather than cleaners. They make the situation inside the plaque progressively more dangerous. Specific anti-inflammatory compounds can shift macrophage behavior from the inflammatory state toward what researchers call the resolving state, where the cells begin to actually clear debris rather than contribute to it. This macrophage shift stabilizes existing plaques and reduces their rupture risk even before their physical size has meaningfully changed. Stabilizing a vulnerable plaque is, in cardiovascular terms, just as important as shrinking it. The fourth mechanism is endothelial repair signaling. Your body maintains a population of circulating endothelial progenitor cells, essentially a repair crew that is supposed to mobilize from bone marrow, travel to sites of arterial damage, and patch the endothelial lining. In people with chronic inflammation, poor nutrition, and sedentary lifestyles, this repair crew is both smaller in number and slower to respond. The damaged endothelium stays damaged longer. Plaque formation continues unopposed. Specific flavonoid compounds have been shown to measurably increase both the count and the mobilization speed of these progenitor cells, essentially restaffing the repair crew. The difference between a vascular system that repairs itself efficiently and one that cannot keep up with ongoing damage is, over the course of years, the difference between arteries that stay functional and arteries that progressively deteriorate. Now let me show you what the research says about dietary compounds and these mechanisms. A controlled trial from the University of California, San Francisco, followed 146 adults with documented endothelial dysfunction. Participants who consumed a polyphenol-rich beverage each morning over 30 days showed a 32% improvement in flow-mediated dilation, the gold standard clinical measure of endothelial function, compared to the control group, alongside significant reductions in oxidized LDL, the specific particle most responsible for foam cell formation. A 12-week randomized trial from the Karolinska Institute in Sweden followed 89 individuals with early-stage atherosclerosis confirmed by carotid intima media thickness measurements. The intervention group consumed a standardized daily dose of a quercetin and allicin-containing preparation each morning. At 12 weeks, ultrasound measurements showed a statistically significant reduction in carotid intima media thickness, a direct structural measure of plaque burden, compared to the placebo group. Researchers also observed a 28% increase in circulating endothelial progenitor cell counts. Harvard Medical School researchers analyzing data from the Nurses' Health Study and the Health Professionals Follow-Up Study, tracking individuals over 20 years, identified that those in the highest quartile of dietary polyphenol intake had a 34% lower rate of cardiovascular events, even after controlling for smoking, exercise, and baseline cholesterol. The most protective compounds were flavanols and organosulfur compounds. A 2019 mechanistic study from McMaster University demonstrated that berberine at 500 milligrams daily for 8 weeks significantly shifted macrophage polarization away from the inflammatory phenotype toward the resolving phenotype. The immune cells inside plaques stopped behaving like arsonists and started behaving like cleanup crews. And a 2021 meta-analysis covering 18 randomized controlled trials found that daily consumption of nitrate-rich foods combined with flavonoid-rich beverages produced synergistic improvements in endothelial nitric oxide bioavailability, approximately 40% greater than either intervention alone. That synergy is central to why the morning drink I am about to describe works better as a combination than as any single ingredient would. Now, let me build the drink. The foundation is 200 milliliters, approximately 3/4 of a cup, of raw beetroot juice. Beets are among the richest dietary sources of inorganic nitrates, which your body converts to nitric oxide through a two-step enzymatic process. That conversion is significantly more efficient in a fasted, slightly acidic stomach environment, which is why the morning timing matters. Fresh pressed is ideal. Cold pressed bottled beetroot juice without added sugar works equally well. Look for a product with at least 300 milligrams of nitrates per serving. The second component is 1 teaspoon of freshly grated ginger, approximately 5 grams. The active compounds in fresh ginger, gingerols, and shogalls inhibit platelet aggregation through a mechanism similar to low-dose aspirin, without the gastrointestinal side effects. They also suppress NF-kappa B, one of the primary inflammatory signaling molecules driving endothelial dysfunction. Grate the ginger fresh and add it directly to the beetroot juice, or steep it briefly in warm water and combine. The third component is the one most people skip, and it may be the most important of the 5. Half a clove of raw garlic, approximately 1.5 grams, finely minced or pressed. When garlic is crushed or minced, it triggers the enzymatic formation of allicin, an organosulfur compound that enhances HDL functionality, inhibits LDL oxidation, and directly suppresses the inflammatory macrophage signaling that makes plaques dangerous and unstable. Allicin degrades rapidly after formation. It must be consumed within 10 minutes of crushing. Do not use garlic powder. Do not cook it. Raw, freshly minced, left to sit for 60 seconds to allow allicin to form, then added to your drink. If the taste is challenging, and for some people it is, swallow it with a small spoonful of raw honey immediately after. The fourth component is the juice of half a fresh lemon, approximately 30 milliliters. Vitamin C from fresh lemon juice serves 2 specific functions in this combination. First, It recycles oxidized nitric oxide back into its active form, extending the vasodilatory effect of the beetroot. Second, it enhances the bioavailability of the flavonoid compounds in ginger by preventing their degradation in the gut. Do not substitute bottled lemon juice. The vitamin C content is substantially lower after pasteurization. Fresh only. The fifth component is 1 teaspoon, 15 milliliters, of raw, unfiltered apple cider vinegar. Acetic acid in apple cider vinegar suppresses the hepatic enzyme that regulates VLDL production, the lipoprotein most associated with triglyceride-rich atherogenic particles. It also creates a mildly acidic gastric environment that optimizes the nitrate to nitrite conversion. Use unfiltered with the mother for the additional polyphenol content. Add it last and stir. And if you want to amplify the anti-inflammatory effect further, add a 1/4 teaspoon of turmeric and a small pinch of black pepper. Curcumin, the active compound in turmeric, is a potent suppressor of macrophage-mediated arterial inflammation. On its own, its bioavailability is poor. Piperine from black pepper enhances curcumin absorption by a factor that has been documented across multiple pharmacokinetic studies as extraordinary. Adding a small amount of healthy fat at breakfast, olive oil over toast for example, boosts absorption further still. Combine everything, stir or blend briefly, and consume immediately. Do not let it sit. The active compounds, particularly the allicin from the garlic, degrade within minutes. Beyond the morning drink, 4 supporting foods compound the benefit throughout the day. With lunch, have approximately 120 milliliters of unsweetened pomegranate juice or half a cup of pomegranate seeds. Pomegranate contains a class of polyphenols called punicalagins that are metabolized by gut bacteria into urolithins, compounds that reduce arterial wall inflammation and support endothelial progenitor cell mobilization. A landmark study published in Clinical Nutrition followed patients with carotid artery stenosis for 3 years. Those consuming pomegranate daily showed a 35% reduction in carotid intima media thickness. The control group showed an 18% increase. That is a dramatic structural difference, measurable by ultrasound, from a dietary intervention. 2 to 3 times per week, eat 100 to 150 grams of wild-caught fatty fish, salmon, sardines, mackerel. EPA and DHA from marine omega-3 fatty acids incorporate directly into the phospholipid membranes of endothelial cells, increasing their fluidity and reducing the rigidity that drives plaque adhesion. They also suppress leukotriene production, inflammatory molecules that are consistently elevated in vulnerable plaques. Frozen wild salmon is nutritionally equivalent to fresh and considerably more economical. Every day include 2 cups of dark leafy greens, raw or lightly steamed. Spinach, rocket, and Swiss chard are particularly high in both dietary nitrates and lutein, a carotenoid that research has shown reduces arterial inflammation independently of its antioxidant effects. The nitrate content is highest in raw rocket. If you are cooking your greens, light steaming rather than boiling preserves the water-soluble nitrates that boiling leaches into the cooking water. And daily, eat 30 grams of walnuts, a small handful. Walnuts are the only tree nut with a meaningful ratio of ALA omega-3 to omega-6 fatty acids. They also contain L-arginine, the direct amino acid precursor to nitric oxide, in concentrations that measurably raise plasma levels within 2 hours of consumption. A Penn State study found that daily walnut consumption over 6 weeks reduced both central aortic pressure and non-HDL cholesterol compared to a standard Western diet. Now let me give you 5 things that determine whether this protocol produces results or produces nothing. Details that most people miss and that silently undermine everything else. The first is the mouthwash timing. The nitrate to nitric oxide conversion that makes beetroot juice so effective depends on oral bacteria that are only present in meaningful concentrations before you have brushed your teeth or used antibacterial mouthwash. Research is unambiguous on this. Using mouthwash before your morning drink reduces the nitric oxide yield by up to 90%. The sequence is drink first, brush after. Your oral hygiene is not compromised. You are simply ordering the morning correctly. The second is temperature. Consuming your morning drink warm rather than cold mildly stimulates vagal tone and relaxes arterial smooth muscle even before the bioactive compounds are absorbed. This is measurable on blood pressure monitors in clinical settings. Not dramatic, but real. If the full beetroot combination is too intense for you initially, warm water as the base makes the transition easier. The third is what you track. Most people monitor total cholesterol. Ask your doctor for 2 additional markers: oxidized LDL and high-sensitivity CRP. Oxidized LDL is the specific lipoprotein fraction that initiates foam cell formation. High-sensitivity CRP reflects the systemic inflammatory burden that destabilizes plaque caps. These 2 numbers are far more sensitive indicators of actual arterial risk, and they respond most visibly to the interventions we have discussed. They are also the numbers that will give you the clearest feedback that the protocol is working. The fourth is the 4-week threshold. Most people expect to feel different within days and give up after 2 weeks when nothing obvious has changed. The vascular adaptations from dietary polyphenols and nitrates are real, but they accumulate gradually. Endothelial function improvements are typically measurable at 3 to 4 weeks. Structural changes in plaque burden take 8 to 12 weeks minimum. This protocol works invisibly. Arterial plaque does not produce symptoms until it is very advanced. The absence of symptoms is not evidence the protocol is not working. It is precisely the goal. Commit to 4 weeks of daily consistency before you evaluate anything. The fifth is the whole food principle. People often replace raw garlic with a garlic capsule, beetroot juice with a nitrate tablet, ginger with an extract. The bioavailability and synergy effects from whole food forms are consistently superior in the vascular research literature. The food matrix, the fiber, water, cofactors, and co-occurring compounds, is part of the mechanism. Supplements can support the protocol. They cannot replicate it. One safety note I want to be direct about. If you are on anticoagulant medication, warfarin, rivaroxaban, apixaban, or similar, please speak with your doctor before starting this protocol. Both garlic and ginger have meaningful effects on platelet aggregation, and combined with anticoagulant therapy, the blood thinning effect requires medical oversight. Similarly, if you are on statins, calcium channel blockers, or antiplatelet drugs, avoid grapefruit during this protocol. Grapefruit contains compounds that inhibit the enzyme responsible for metabolizing many cardiovascular medications, which can unpredictably raise medication blood levels. Stick to lemon and pomegranate for your citrus. Let me bring everything together clearly before I close. Arterial plaque is not a fixed, irreversible structure. It is a living, metabolically active process that responds to specific biochemical inputs, including foods you can access today. The 4 key mechanisms are nitric oxide restoration, reverse cholesterol transport, macrophage stabilization, and endothelial repair signaling. The morning drink addresses all 4 simultaneously through a combination of raw beetroot juice, fresh ginger, raw minced garlic, fresh lemon juice, apple cider vinegar, and optionally turmeric with black pepper. The 4 supporting foods, pomegranate, wild fatty fish, dark leafy greens, and walnuts, compound the vascular benefit throughout the day. The critical practical rules are these. Drink it fasted, approximately 20 minutes before breakfast. Do not brush your teeth or use mouthwash first. Do not cook the garlic. Allicin is destroyed by heat and does not survive in powdered or processed form. Track oxidized LDL and high-sensitivity CRP alongside your standard cholesterol panel. And give this 4 weeks of genuine daily consistency before you assess any results. Your endothelium can produce nitric oxide. Your HDL can transport cholesterol out of plaque. Your endothelial progenitor cells are waiting right now, ready to repair arterial damage the moment you provide the biochemical signal to mobilize them. These systems exist in you. They are not gone. They are under-supported. The question is not whether your body can do this. It can. The question is whether you are giving it what it needs to do it. If this was useful to you, please subscribe to the channel and share it with someone who has been told their cholesterol is fine, but whose cardiovascular risk still concerns them. The gap between a normal standard lipid panel and genuinely protected vascular function is significant, and they deserve to know that gap exists and that something can be done about it. Leave a comment below. I want to know whether you have ever had your oxidized LDL or high-sensitivity CRP tested, and what those numbers showed. Your responses help me understand what this community needs most. I am Dr. Julian Cross. Take care of yourselves, and I will see you in the next one.